And good afternoon, and welcome to the Davies Use Case webinar being presented by Unity Healthcare on hypertension. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm Quality and Patient Safety, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health IT to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and IT-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information technology to improve patient outcomes and value. The Davies Award winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes, resulting from health IT-enabled care delivery. And it's my pleasure to welcome our speakers to today's call. We have Dr. Angela Diop, who is the Vice President of Information Systems at Unity Healthcare. At Unity Healthcare, and a federally qualified health center providing medical homes to over 105,000 residents in Washington, D.C. Dr. Diop has led the adoption and expansion of health information technology throughout Unity's more than 25 sites. Under her leadership, Unity earned the Health Information Systems Society HIMSS Davies Award in 2012 and now in 2017. Dr. Diop is an active member of the District of Columbia Health Information Exchange Policy Board. Over the past 10 years, Dr. Diop has worked to realize for both Unity and its patients the transformative power of information technology to engage, improve the health of community. And we also have Dr. Kathy Anderton. She's been Associate Director for Quality Improvement and Research at Unity Healthcare since 2013. She leads the organizational quality improvement initiatives, including interdisciplinary learning collaboratives, working groups, and targeted site interventions. She represents Unity Healthcare in population health collaboration with community, professional, and governmental organizations, including the CDC's Million Heart Campaign and AMGA's Measure Up and Pressure Down, and Together to Go initiatives to improve the treatment of hypertension and diabetes in primary care settings. She's an honors graduate of the University of Illinois College of Medicine. And ladies, I'll turn this over to you all. I'll give you the ball here.
And this is Angela Jope speaking. A bit of time talking about Unity Healthcare and who we are, and then I'm going to turn it over to Kathy, and she will walk us through our hypertension case study. No one achieves Davies on their own. It is organization-wide achievement, but we also want to recognize some of the other members on our Davies application team. Besides myself and Kathy, we're joined by Marcia Hinkle, Sheree Jones, and Dr. Andy Roby. Unity is a federally qualified health center in the District of Columbia. We served over 106,000 patients last year and with 500,000 visits. And our mission is promoting healthier communities through compassion and comprehensive health and human services, regardless of the ability to pay. And we've been at this for a little over 30 years. A number of sites and services throughout the district, and these sites include community health centers. We actually have sites and centers, a substantial homeless and outreach program that we do with homeless outreach in a mobile van. And in addition, we provide health services in the DC jail. The services include care. A number of our sites have dental care. We do provide behavioral health care, and then we provide care to special groups of people. For example, people experiencing homelessness, people with HIV, returning citizens, and we are patient-centered medical homes and CQA Level 3 recognized organization. Just a little bit about our technology platform. We do have a highly customized integrated practice management and electronic medical record. In addition to that, it's highly accessorized with special applications such as dental, patient portal, and a number of other things. We've had this in place since 2009, and this technology is used by over 260 providers, and nearly all of our 1,000 member staff uses the technology. And its primary maintainers, the technology itself is about the change management system that kind of undergirds our technology and what we feel has as a recipe for and our ability to use the EMR as an enabling technology. And that change management system has got three major pillars: governance, support system, as well as training. And this has actually served us well in allowing us to develop and adopt well-thought-out changes in an organized manner. To the hypertension case study that Kathy will be presenting. For the governance of the electronic health records. And there are many teams. I could actually do a whole presentation on that in itself. However, the key teams that are part of record are each our stakeholders team that's got responsibility to bringing to bear the resources needed and the prioritization or the changes needed. An implementation team that really carries all of that out. A reports team that makes sure that, how we're putting it in, we're able to sort of get it out and measure what we're doing, and a configuration create technology or in the EMR. Take our, first of all, to develop the workflows, first and foremost. And this is something we learned over time. We did start with trying to modify an EHR without developing workflows, but that doesn't work too well. Then we modify the EHR based on the workflows. And most importantly, we train staff. And we feel like this is what results in the changes that you're going to see. A little bit more on workflow development. Developed by that are representative of people in the organization that will be using the electronic health records. And this particular case study, which is typical of most of our changes, we worked with QI department, and within the QI department, they actually We have working groups that work on projects, and in this case, we actually had a hypertension working group. And we paired that with a configuration team that figures out how we want to modify the EHR so that the staff use it to capture work that they're doing. All of these groups are working in collaboration with our technology group, our health information technology team, as well as the report. Once that changes develop, we work training, they develop training, and they roll it out. The rollout is a multidisciplinary team-based training. We've actually had a lot of success with that and have a particular case study. We'll talk about that. We make sure we actually reinforce training. That's one of the things we've sort of learned over time, that one training is probably not enough. And again, that results in. With that, I'm actually going to head over to Kathy. She's going to talk a little bit about the specifics of our hypertension study. Clinical scenarios that we've configured EMR for specifically. So why hypertension in particular? And you will realize it's both a local and a national problem. Nationwide, heart disease remains the #1 cause of death in the United States. You can see from the chart on the slide that the situation in the nation's capital is mortality rate from heart disease than in the United States as a whole. One geographic and racial in the District of Columbia in the prevalence of hypertension. African American residents of Washington are 2 times likely to have high blood pressure as white residents, and even more tragically, they're twice as likely to die from stroke as white residents. You can see on the graph that the prevalence of hypertension varies significantly from one ward to the next in the district. The district is divided up into 8 wards. Wards 7 and 8, you can see on the far right of the graph, are predominantly African American. So, hypertension is the leading diagnosis affecting Unity Healthcare patients. We have more than 20,000 patients with hypertension.
Significant disparity in the prevalence of hypertension in the District of Columbia. You can see that the district is divided into 8 wards. Wards 5, 7, and 8 are predominantly African American. The prevalence in those wards is much higher. Residents of the nation's capital are 2 times as likely to have high blood pressure as white residents of the district, and even more tragically, they're twice as likely to die from stroke as white residents. So it's is an everyday challenge at Unity Healthcare. It's the #1 diagnosis affecting our adult patients. We care for more than 20,000 hypertensive patients every year. That's more than 1 in 5 of Unity's adult patient population. So what was the configuration effort? We decided that we wanted to concentrate on increasing the percentage of patients with an established diagnosis of hypertension whose blood pressure was controlled. We looked at our data generated from the EMR and saw that we did a pretty good job of identifying patients and diagnosing them with hypertension when they had repeated elevated blood pressures. So we didn't think that that was our first priority. We are much more challenged in establishing good control amongst the patients that we knew to have a diagnosis of hypertension. Our baseline in December of 2013 was just 54% of patients diagnosed with hypertension controlled with a blood pressure reading less than 140/90. We reported this work that we had an alignment of both organizational and nationwide priorities. Our Unity Organizational Balance Scorecard had controlling hypertension as one of its two important clinical measures. We had a target of 64% of patients with hypertension control. We also happened to coincide with the CDC's Million Hearts campaign to prevent 1 million heart attacks and strokes, and one of the primary methodologies for achieving that was intended to be better control of hypertension. And from our balance scorecard in the bottom of the slide. And earlier, we always start by analyzing our workflow and asking ourselves, what is the ideal workflow that we want the EMR to support? So we started at the beginning, the medical assistant measures the blood pressure. We knew from AMGA's Measure Up, Pressure Down campaign that a fundamental priority is making sure that the staff are measuring blood pressure correctly, not just to have the correct number, but also so that all the other members of the team, when they see that number in the chart, feel confident that it is correct and will act on it. So we knew that we wanted to support the MAs using proper techniques. Next, we wanted to address the role of the provider. The provider assesses the patient and particularly looks at any barriers that the patient might have to achieving blood pressure goals. What might be getting in the way of a patient who seems to be prescribed the proper medication, actually having those medications achieve their best effect. And part of that treatment plan is appropriate follow-up. We always struggle with optimizing access of our patients to care. Providers are in great demand. Sometimes a follow-up plan can be hindered just by the sense of there's no room in the schedule. So we knew that that was something that we wanted to address as well. Ideally, we wanted follow-up of patients who were not at goal in 30 days or less. And clerk schedules any needed follow-up visits. And then we added a fourth part of the workflow, which is an expanded role for the nurse in following up with those patients who had an established diagnosis of hypertension and had not yet gotten to goal. We wanted to have a much more robust system for follow-up with the nurse in order to take some of the pressure off of the provider. IT to achieve those goals. And it seems like a very small thing, but it really wasn't, was we talked everyone into making the blood pressure measurement from the standard vital signs of every visit turn red at 140/90. Rather than turning red at a higher measurement that would be more like a panic value. That's how it came to us out of the box. We wanted to go from a panic value attitude about hypertension to a goal-driven attitude where we want patients at goal. I really think this was one of the most effective interventions we had, and it was a very simple one. The alerts the treatment team to medication allergy and medication-medication interaction. and there's an automatic formulary check to make sure that the medications that the provider is prescribing are actually financially available to the patient. Those are also meaningful use measures. That we looked at was clinical decision support for providers. We, as an organization, had decided to adopt the JNC8 guidelines, and so we wrote them into the configuration for hypertension into the history of present illness section of the note. So you can see the first screenshot at the top of the page. It says BP goal colon, and then it says 140/90 per JNC8, and then it runs off of the page, but it tells you why. And there's actually another choice if the patient falls into a different JNC8 category for blood pressure goal. These to helping providers to adhere to the guidelines, the blood pressure goal as the first item in the HPI was also meant to address treatment inertia that we sometimes see when patients are close to goal but are not at goal. The note that we configured was the preventive medicine section. In our EMR, this is a section that comes at the bottom of the note. It prints out on the visit summary for the patient, and it's a place where we can put patient education and where we can reiterate what the blood pressure goal is for the patient. We also included timely follow-up in that section of the progress. All right, it was actually create a new visit type and an EMR template to go along with that visit type. This is the nurse blood pressure follow-up visit. We created a template so that the EMR could support nurses working relatively independently and for them to be able to know when they need to immediately refer the patient back to the provider so that they could provide standardized patient education and that they could correctly document and code the notes so that it was a billable visit. And you can see at the top of the slide some of the patient information in PDF that's available through the EMR, and at the bottom of the slide is the very first lines of the nurse blood pressure visit template. It was both a patient safety feature of the EMR and also a feature that promoted proper documentation. Throughout, data-driven, and we tried to use data to tell the story of the work that we were doing to the rest of the Unity staff. We generated a lot of reports from the EMR. This is just a couple of examples. The image you can see at the top right, this is us looking at how good a job we were doing repeating a blood pressure reading after 5 minutes of rest if the initial reading taken by the MA was elevated. That's part of the correct measurement of blood pressure. You can see that we had some health centers that had really, really dramatic changes in how they measured blood pressure. So increases all the way up to 60 percentage points in repeating the measurement when indicated. On the bottom left, you can see a run chart that was shared with the QI committee. This documents the rate of blood pressure control over time, and it indicates when each of our interventions were made and helps you see what the effect of those interventions might have been. All of this configuration work, we needed to turn to staff training. As Angela mentioned, we rely on interdisciplinary team-based training. We try to get all the team members together to discuss their roles, make sure that everybody's on the same page. Initially, we do this organizational-wide via webinar. So we train the staff in The JNCA guidelines, the proper techniques for taking blood pressure, how to document, and how to follow up. We recorded the training and put it on our learning management system, and then we watched to make sure that the staff members had actually attended the training. Some fun and engaged staff members on a different level. So Dr. Andy Roby actually created what you see on the right-hand side, which is Unity's Heart of Gold Award. It's an anatomic model of a heart, spray painted gold and put on the trophy base. We've given out this award 3 times to 3 different health centers. The first is the one that's pictured here. This is Columbia Road. They won for the highest rate of blood pressure control amongst their patients with hypertension. We awarded it again about a year later for the health center that had the highest rate of repeat visits within a 30-day period for patients who weren't at goal. And then our most recent awardee won for having the greatest rate of improvement in control over a 3-month period. And it's been really fun to trade this award around, and it's been actually very powerful in getting the health centers engaged in this work. We also make sure that we were engaging patients. You can see on the right example of posters that we put up at our health centers letting patients know what quality measures we were working on particular at any given time. You can see blood pressure is the second one listed. We really did try to increase the number of patients who saw us again within 30 days when they weren't at goal. We tried to make that more possible by creating nurse visits for repeat BP checks. The EMR also sends out automated reminder calls for appointments, and we shared our goals with patients in the preventive medicine section, as I mentioned earlier. Whoops, I am out of there altogether. I'm sorry. So what value did we derive from all of this work? I think one of the most powerful things that we got out of our hypertension work was creating a culture of data-driven intervention. And you can see an example of that from the very beginning of this campaign. We tried to address what was a very strong belief that our rate of poorly controlled hypertension was being driven primarily by patients who came in unscheduled as walk-in patients. So we just queried the EMR and asked, where are our patients showing up with uncontrolled hypertension? Are they our walk-in patients or are they scheduled patients? And lo and behold, they were almost entirely scheduled patients. So we shared this data with the healthcare teams, and it really was powerful in initiating discussion about how can we conduct our scheduled visits differently in order to have a better outcome for these particular patients. This preliminary phase here of just looking at the data. And then phase 1 was the provider configuration, the what we called the RED, rest, repeat training for staff on proper BP measurement technique. The RED was that 140/90 turning red in the vital signs on the screen. And then the final phase was the nurse BP visit, the template, and the workflow for those visits. Over the course of several years, you can see that we had almost 10 percentage point improvement in blood pressure control amongst our patients with hypertension, and we've been able to sustain that improvement over time. We calculate that we had about a $400,000 increase in revenue that was generated by the nurse visits for BP recheck. ROI, we had increased access because of those new nurse visits. We hope increased provider satisfaction from having to support their work in hypertension control. We expanded the role of both the medical assistants and the nurses, and we hope that we improved team efficiency as well. It was certainly easier to get things done when our QI and HIT goals aligned with greater corporate goals. Using multidisciplinary teams through all phases of the project, we thought also significantly increased the impact of our efforts. We had to plan training, and then after we conducted the training, we realized that we also had to plan how to reinforce it. So we actually did a little bit of a scramble after those initial team-based trainings and went back, sometimes actually often in person, site by site, and reinforced what we had trained initially on an organization-wide level. And that reinforcement of the training face-to-face was very powerful. Doing the project in phases, especially to incorporate the feedback from staff from the initial phase in the later phases of the project. We were also constantly reminded that we needed to think more broadly about which team members were going to be affected by the changes that we were making. We did a couple of times forget that we would be impacting people on the team that we were not thinking about. So the registration clerks, for example, we didn't think when we created the nurse visit types that we would have to teach them about that, and we initially accidentally left them out of the project. So that's something always to keep in mind.
Well, thank you for that presentation, and thank you for joining us on this Davies webinar. I just want to remind viewers where they can find more Davies use case webinars and information on how to apply for Davies. That information can be found posted at the HIMSS Davies Award website at hims.org/Davies.